indispensable tool in women. And this is both in obstetrics and gynecology. And in our environment, the maternal mortality is very high. In fact, it is in 3 to 4 digits, 150 to 100,000 deaths. The same with neonatal mortality, which is in the range of 20 to 40. So compared to other environments, our maternal mortality is so high and is like we cannot accept to go on in this direction. So any instrument of care that will improve or reduce the maternal mortality, perinatal mortality is a good one. And that is why ultrasound comes in handy in this respect. So, but you cannot use ultrasound without training those who are going to use it to manage patients. And that is why we should understand that training in ultrasound is key in saving women and fetuses. So healthcare personnel at the primary healthcare level are the first point of contact for women in need. And these personnel need to be empowered with all instruments of care, including ultrasound. And providing basic training in ultrasound should be all-encompassing and should be provided to doctors, nurses, midwives, and even CHUs. Even though I put a question mark on CHUs, but we should understand that it is a policy of the Nigerian government that tax shifting has come to stay. So whether we like it or not, we have to do with it. So even CHUs can be trained in this particular area. Now, let me say that basic ultrasound skill should empower healthcare personnel to identify conditions early and to help them in starting interventions. And those interventions should go a long way in mitigating the problem, or help them after identifying the problem to refer the patient to appropriate facility where the case can be handled. And for basic ultrasound training, there are principal areas which you cannot neglect. And there are 4 of them that I've chosen, even though there may be others. Fetal biometry is important, fetal anatomy, the placenta, amniotic fluid, and like I said, there are others, as we are going to see as we go through the lecture. So basic fetal biometry is key to diagnosing preterm labor, post-death pregnancy, evaluating IUGR, and fetal macrosomia. So that is why we have to understand fetal biometry very well to enable us go through all these cases that we see on a daily basis in our clinics. So the first fetal biometric parameter we are going to talk about is the Crown-rump length, so the so-called CRL. And the Crown-rump length is measured starting from 8 weeks to 13 weeks 6 days. And the Crown-rump length is measured as the greatest length in a straight line from the cranial to the caudal end of the body of the fetus in the straightest possible position of the fetus. And it's good to mention that it is the most accurate method for gestational age determination if you can cut the patient within that gestational age bracket. And we have to capture the image of the fetus in a mid-sagittal section. And the fetus should ideally be horizontal. And the angle of insolation should be 90 degrees to the plane of section of the fetus. And the fetus, again, should be in neutral position, not hyperextended or hyperplexed, because doing that will give you inaccurate measurement. The image should fill at least 30% of the monitor screen. And we have to place the caliper, the intersection of the calipers on the outer borders of the head and the rump. And ideally, we should measure 3 discrete CRLs and get the average. And the degree of accuracy is within 3 to 5 days. So you can see that it is the most reliable as far estimation of gestational age is concerned. Now, looking at this image on the screen, you can see that this image has satisfied all the criteria I mentioned. The fact that the resolution is good will help you to identify the top of the head and the rump. Then you can see that the angle between the chin and the chest is not so narrow and is not so wide. And that will ensure that this fetus is in neutral position, because if there is hyperextension, you will have an exaggerated CRL. And also, if it is hyperplex, you will have a reduced CRL. So these are the criteria that must be fulfilled. And as you can see in this image, that has already been captured. And that is the way you will measure it as we go through the practical sessions during the workshop. And the next parameter is the biparietal diameter. It is the first ultrasound parameter to determine gestational age and also assess fetal growth. And the optimum time for measuring the biparietal diameter is between 12 weeks to 24 weeks. That is not to say you cannot use it beyond 24 weeks. You can use it any trimester, but I'm talking about the optimum time. And the variability of the biparietal diameter in terms of accuracy is 1 to 1.5 weeks. And subsequently, this increased to 3 to 4 weeks. So the precision tolerance of biparietal diameter decreases in the third trimester. So you can see, based on this information, that the optimal time for measuring the biparietal diameter is within that gestational age bracket of 12 to 14 to 24 weeks. And the plane of section is a transthalamic plane. The image should be well magnified. The head should be oval in shape and symmetrical, and it should be horizontal. Now, the landmarks that you have to identify to ensure that you are in that transthalamic plane include the falx cerebri, the cavum septum pellucidum, and the thalami should be located symmetrically on each side. So if you have this, be rest assured you are in the transthalamic plane and you can measure your biparietal diameter. Now, looking at the image, this particular image, the first one, if you look at it, it has all the elements that I mentioned, the landmark that I mentioned. So looking at it carefully, we can see that all the all the landmarks are captured. You can see the telomere here. You can also see the cavum septum. You can see the pulse. So all the parameters or all the landmarks in this image are demonstrable. Now, to measure the biparietal diameter, you have to put your cursor outer to inner, as I'm trying to demonstrate here. But this is based on people's idiosyncrasies. Some people will say outer, inner, but whichever one you prefer, you can use it. But the most important thing is to make sure that the line of the cursor is bisecting the midline of the fetal head. And that will give you an angle of 90 degrees. And that will ensure that you get an accurate biparietal diameter measurement. So looking at this image, at this particular image, the last one on the right, you can see that it has demonstrated the actual measurements. Then in the same plane, you can also measure the head circumference. And the head circumference is less affected than biparietal diameter. Is less affected than the biparietal diameter by the shape of the head and fetal presentation. And that is why it is considered as more important than the biparietal diameter in gestational age assessment. And it is demonstrated the way you are going to take its measurement. Actually, the best way to do it is to put your cursor at one point, fix it, and carry it through the midline so that when you come to adjust your ellipse to accommodate the circumference of the head, there will not be any outliers as you do it. So The next one is the abdominal circumference, so-called AC. Abdominal circumference should not be used for gestational age determination. However, it is one of the key dimensions in assessing intrauterine fetal growth restriction and fetal macrosomia. The image should be well magnified, as in the others that I've described. And the section should be circular. And landmarks, as in the other parameters, should also be identified. Number one, the short segment of the umbilical vein in the anterior third of the fetal abdomen at the level of the portal sinus. Then you have to also see the stomach bubble and a rib at the upper, one rib at the upper, and one rib at the lower edges of the fetal abdomen. And then you also need to show the fetal spine around 3 o'clock position. Now, you should not go so down as to see the fetal bladder and the kidneys, because if you do that, it means you are not taking the measurement at the correct plane of section. So the fetal bladder and the fetal kidneys should not feature in your image. So looking at the images here, the first one with the numbering is the one that demonstrates all the elements or all the landmarks to be captured. You can see number 3 is the fetal spine at about 3 o'clock position. Number 2 is the fetal stomach. Number 3 is the short segment of the portal vein, of the umbilical vein around the portal sinus. So with this, you can take your measurements of the abdominal circumference. And the last image is showing how that measurement is done. Just like in the case of the head circumference, you fix your cursor to go through, starting from the fetal spine. If you just go in front of the fetal spine, you can see a pulsating vessel. That is the descending aorta. So go through it so that you bisect the fetal abdomen exactly into 2. And you can now adjust your ellipse to accommodate the abdominal circumference, and you can take your measurements appropriately. So the next parameter is the femoral length. This is the largest bone. The femur is the largest bone, and it's the least movable and the easiest to image. And there are reasons to say that, because if you use certain landmarks, the iliac crest, your landmark, the fetal bladder is your landmark, and if you are able to capture that by the sides at the femoral, so you can easily use those landmarks and do the appropriate movement to capture the femur. Now, it is as accurate as the biparietal diameter in gestational age determination, and it is best measured from 14 weeks. And the accuracy of the femoral length in gestational age determination is 2.8 weeks, decreasing with increasing gestational age. So as the gestational age increases, the accuracy also decreases. And it is difficult sometimes in the 3rd trimester to capture the whole length of the femur. This will be experienced as you scan patients. So the femur should be imaged as close as possible to the horizontal plane. And you measure the bone closest to the PROF, okay? And the angle of inclination should be around 90 degrees. And the full length of the femur should be visualized. And the bone should not be obscured by shadowing from adjacent bony parts. And you also need to magnify the image so that the screen, about 30% of the screen is accommodated by the femur. And you should not include the trochanterus, because what you are measuring is the diaphyseal length. And if you include the trochanter, you are going to have an exaggerated and inaccurate femoral length measurement. So you should be mindful of that. So this image captures how we measure the femoral length. And you can see that the courses are appropriately placed, only capturing the diaphysis. You can see that the epiphyses are not included. If you do that, that will mean that you will have an exaggerated length, femoral length, and that will not be accurate when ultimately you use it to estimate gestational age. So that's why we have discussed basic fetal biometry. And for any beginner of ultrasound or obstetrics has to learn about this. Now, another area that a beginner should learn is in the diagnosis of multifetal pregnancy. Now, it is essential that even those who are beginners in obstetrical ultrasound should be able to know how to identify multifetal pregnancies. And there are simple signs that with the experience you will understand them and you will be able to identify them as they present in any patient. The first one, well, let me say that this diagnosis of multifetal pregnancy is based on in the late first trimester and early second trimester. And it is because at that time you can see the whole uterus, the whole of the uterine content, and you can identify all the gestational sacs. So the first sign to know is the lambda sign. The next is the T sign. And the other one is the Mercedes sign. And the Mercedes sign is just meant to identify triplets. So that is why it is there. So you can see these three signs. The first one, you can see that the chorion has gone into the dividing membrane. You can see two sacs, and that is the part of the chorion has gone into the dividing membrane, and it gives you that classical lambda sign pattern. Now, the next is the T sign. If you look, you can see two gestational sacs, then the separating membrane is making a T with the base of the chorion. There is no chorionic tissue going into the separating membrane. I give you this classical T sign pattern. Now, the other one is the so-called Mercedes sign. You can see that there are three gestational sacs. And the image, if you compare it with the logo of the Mercedes-Benz car, they look alike. That is why it is called the Mercedes sign. Now, another area which is essential in basic fetal ultrasound, you may not go into the details that you identify, even though you are a beginner. Now, those areas are the fetal spine, the fetal abdomen, the fetal heart, fetal kidneys, and fetal brain. These are the essential organs or parts of the fetus that you have to identify and be clear about, so that if there are abnormalities, you will be able to see them and appreciate them. Now, looking at this image, is the image of the cross-section of the fetal abdomen at the point of cord insertion. Now, if you look closely, you will see some lines, hypoechoic lines, three of them. These are the umbilical cord vessels. And you can see clearly the umbilical cord is going into the fetal abdomen at that level. Now, if you are able to see this, then you will be able to rule out omphalocele and gastroschisis. And that is why capturing this image is essential, because even for you as a beginner, you'll be able to see there is no gastroschisis and there is no omphalocele. So the next is at the fetal kidneys. How do you identify the fetal kidneys? There are two ways. One is the one I have just presented in the slide here. You will see that is a transverse section of the fetal abdomen at the level of the lumbar region where the kidneys are located. Now, you can see clearly the fetal skin covering the spine. The arrows are pointing to the kidneys on one side and the other sides. And the shadow that is in between is the shadow casted by the fetal spines. So if you have this image, you'll be able to see the kidneys, and you may even be able to say they are looking normal or they are not looking normal. For example, if you have multicystic, macrocystic kidneys, it's obvious that you will see the cysts within the kidneys. Or you have some level of hydronephrosis. You will be able to see dilated calyces. But if it is as is seen in this image, then it means it's normal. So this you can do in a transverse section of the fetal abdomen at the level of the lumbar region. But you can also image the kidneys, the two of them at the same time, if you take a coronal section. But it's not easy for all of us to get a coronal section that will demonstrate the presence of the fetal kidneys. To be able to see these spine bones going parallel to each other and only converging toward the coccyx. Okay? Now, on top of the spine, you will be seeing a very thin epigenic line covering the spine, and that is the skin covering the spine. Now, if you can see this clear skin without something protruding or pushing out, it means that you are ruling out spinal dysrhythmias, like spina bifida and its variants. So it's very important, and this is an image in the what do you call it? The sagittal plane, whose experience will be able to identify all the structures and be able to rule out spina bifida. The next, the fetal heart is a wonderful structure. So the first thing to know is first to say the heart is with Topia cordis. You will see the heart. It may have even 4 chambers, okay, but it's not in the thorax. And that means it's not a normal, and that means it may be associated image at the level of the thorax. In cross section, you'll be. So the next thing is to identify the chambers. Even though my teacher will say it's not the chambers you identify, you name the chambers with reasons to say, okay, this is the left. This image, in this image, the spine is lower down, and just above the spine, sending out, you see chambers that are close to that at the left. So whenever you see the outer and you see the chambers close to it, you are talking about the left side of the heart. Now, the right side is the right atrium and the right ventricle. And the right ventricle is characteristically identified because it has the motor band. And then there may be others as you acquire more and more experience. I mean, in checking the normality or abnormality of the heart. Things like thoracic, the cardiac axis. But if you can see port chamber, normal port chamber, the rest assured in 60%, the heart that you are imaging is normal. So the other things, because of their importance, is the location of the placenta. And you can see 2 images. In both images, you can see a mass covering the internal os, particularly the one on the left. The internal os is there and is completely covered by the placenta. So even at that point, you can see there is a major degree of placenta previa. And diagnosing placenta previa is very important because that will enable you to learn how to deliver, or if you cannot deliver in your center, you can now refer the patient. So identifying placenta is very important. And this other image is still showing us a major degree placenta previa, type 4 in fact. So this you can do easily if you can acquire the correct image. You can be able to say the placenta is major degree, even if you cannot accurately say it's a minor degree. At least you can identify the major degree placenta previa. So the next area that I would want to talk in basic obstetrical ultrasound is amniotic fluid volume. You can panoramically look at the uterus and its content to say there is adequate amniotic fluid. But that is not objective. So the objective ways are two, principally. Number one is the deepest particle pool. And you acquire the deepest particle pool by dividing the uterine content into 4 quadrants. And then you now explore each quadrant to see which one has the largest amount of amniotic fluid. And then you take your measurement appropriately. And the normal is between 2 and 8 centimeters. Less than 2 is oligohydramnios. More than 2 is polyhydramnios. The other way to do it is to check for the amniotic fluid index. The amniotic fluid index is like you have to image the whole uterus with its content. Also look quadrant by quadrant. You now look at one quadrant, where is the largest pool, you measure it. You go through all the quadrants, identify the largest pool and measure it. The machine will automatically submit it and give you the index. And the normal range is 8 to 25. Less than 8 is oligohydramnios. More than 25 is polyhydramnios. So we should be able to understand that. Now, very quickly, let's briefly look at basic gynecological ultrasound. And in that, we are going to look at the normal uterus, normal ovaries, appearance of the endometrial cavity in the various phases of the menstrual cycle, identify the term products, uterine myomas, endometrial polyp, and molar pregnancy, because these are the major causes of hemorrhage and maternal distress, so to say, because they lead to so many complications in the woman. Therefore, being able to identify them will enable you to offer appropriate treatment. So let's see. The first image is the image of the uterus in sagittal section. And you can see how I placed the cursor and took the length of the uterus from the fundus to the external os. And the normal is up to 7.5 to 9.5. And then you can also take the anteroposterior diameter, and that is up to 4. So anything beyond that, we know that is an abnormality. So that is how the normal uterus appears. Now, sometimes, because of the patient's presentation, you may need to measure the cervical length. So the cervical length, you can see, if you look closely, you will see that the internal os is being identified, and the external os, that is the length of the cervix. And if you look again closely, you will see that at the center, there is a hypoechogenic line that is demonstrating the cervical canal. So what you do is to fix your cursor and then take the measurement from internal os to external os. And the normal is usually 33 millimeters or 3.5 centimeters in length. And you can also do this via transvaginal ultrasound, but you don't need to go to that length. Just use your transabdominal scan and identify the landmarks and take your measurement appropriately. So next, we look at the ovaries. And this is also in cross-section. If you look, there is a pointer, an arrow pointing to the uterus cross-section. So if you look toward the left side, you'll be able to see the left ovary. If you look at the right side, you'll be able to see the right ovary. It is not always easy at the beginning to be able to identify ovaries, but with time and diligence, you'll be able to do that. So that is how they appear. Then, like I mentioned, you need to know how the uterine lining appears in the various phases of the menstrual cycle. And this has a lot of applications. And if you look at this image, you will see that in the midline, there is a very thin echogenic rim from almost toward the fundus coming downwards. And this is what you see in a uterus that has just finished menses. So this is classical of that. The next one is in the proliferative phase. And you know, in the proliferative phase, the thickness is increased. Not only that it increases under estrogenic action, but it is also showing characteristic trilaminar appearance. If you look closely at this image, centrally there is a line, very thin line, which is echogenic. And then above and below it are two other lines. And that is what describes the trilaminar appearance. And this is characteristically what you see in the proliferative phase of the endometrium. And this is under estrogen. You will see pointed by the arrows a thick, homogeneous, echogenic structure. And this is because at that point, progesterone is the dominant hormone, and secretory activity has started. And this is what you see classically when you image the uterus at that time. Don't mind this image that I'm just a little above the homogeneous echogenic area is a hypoechogenic area. You will assume it's a collection of blood or fluid, but don't mind that. It is not supposed to be. Okay? So the next one is to be able to identify return products of conception. If you look at this image, centrally there is mixed echogenic mass at the center of the endometrium and this is classically what you see when you have return products of conception. But that is not to say that you will always rely on ultrasound to make diagnosis of return product. Basically, diagnosis of return product is clinical. It's just to be complemented by ultrasound. Because when you examine the uterus is bulky and you examine the cervical os is open, it means there is something inside. So you should not always rely on that. But when you have an ambiguous case, you can complement your clinical finding with your ultrasonic finding. So the next one again is the mighty uterine fibroid. Uterine fibroid is actually a mixed echogenic mass. But also that will depend on whether there are some degeneration or not. But the classical uterine fibroid is, as you can see in this image. So in this case, it has completely occupied the endometrial cavity. And this is what you see normally when you image the uterus that has uterine fibroid. And sometimes it's not just a single uterine fibroid as demonstrated here. There are multiple areas with similar appearances. And that is talking about multiple uterine fibroid. The next one is the endometrial polyp. If you look, the endometrial cavity has a hypoechogenic area. And then a mass that the arrow is pointing is now like pushing into the cavity. That means part of it is just dangling in the collection, which could be blood, which could be pus, which could be any form of fluid. So this is what you see when you have an endometrial polyp. So I think it's also good to be able to identify endometrial polyps. Now, last but not least, is what you see classically when you are dealing with molar pregnancies. In molar pregnancy, what you see occupying the whole uterine cavity are mixed echogenic areas, subcystic areas, subsolic areas, and this has been described as the so-called snowstorm appearance when you are dealing with molar pregnancy. So, ladies and gentlemen, let me say in conclusion that leave what you are endowed for that which you are in no doubt. In other words, if you do a scan and you are not sure about what you see, prepare your patients. There is nothing to worry about. You cannot be able to diagnose everything. So the best you can do for the patient is not to guess diagnosis and give wrong result. Just refer the patient, having counsel her, she will understand, and she will go and get a better outcome in the next place that she goes to. And she will even thank you for what you did. She knows that you are a reliable person because you appropriately refer her when you are not sure of what you found. So, ladies and gentlemen, I sincerely thank you for your time.
Thank you very much, Professor LABARAN, for the lectures. Thank you so much. We're grateful. I'm sure the participants raised any questions already. So I'm going to read. I have a question in the chat box already. I'm going to read it out. And for others who have questions, please, you can kindly unmute. But let me just read out this one. How do we differentiate endometrial polyp from submucous fibroid? Did you get that, sir? On ultrasound,
hello, I can't hear.
How do we differentiate endometrial polyp from submucous fibroid on ultrasound?
Okay. You see, the main thing is looking at the epigenicity and homogeneity of the mass. So if you are dealing with a submucous fibroid, the fibroids are usually circumscribed and they are usually mixed epigenic. But when you are talking about endometrial polyp, it's not that homogeneous. As you can see, it's more homogeneous compared to uterine fibroid. And it's not like it is circumscribed. As you have seen in the image I presented in my slide, is not looking like a fibroid because it is more homogeneous compared to fibroid, which is heterogeneous because they are solid. Echogenic and less echogenic areas within a fibroid mass. And most often, when we are dealing with endometrial polyp, there is invariably some collection of fluid, which may be blood. And that mass is protruding into that collection of fluid. But in fibroid, usually you don't have that collection. Endometrial polyps somehow are associated with collection of fluid, which is usually blood. And maybe it's because they secrete some blood from the surfaces. But fibroids do not present in such a manner. I hope I'm clear with that.
Okay. Dr. Ajayi? Yes, sir. Thank you very much, sir, for the response. I hope the participant is clear on that response. We have other questions, so I will go on. So thank you, sir, for visualization of the ovaries. Does one need to identify the vascular pulsation around the area of the ovaries? Thank you. So the participant is asking if it is important to localize the vascular pulsation around the area of the ovaries.
Yes, and let me say that for somebody doing basic gynae ultrasound, you may not bother in identifying the vascularity. But if you are dealing with an abnormal ovary, then you may need to do Doppler to identify vessels and the pattern of the vessels, which will betray the diagnosis. Because if you are dealing with a malignant ovary, there will be chaotic vascularization. And that will tell you that this ovary is likely to be malignant. And there are certain criteria that you use in identifying abnormal ovary. But for the normal ovary, which I advocate each of us during the practical session to identify, you may not need to identify vascularity. And I assure you, we are not going to bring a patient with an abnormal ovary. The first objective is to identify a normal ovary before you can check and look for an abnormal ovary. So our aim at the beginning is let you be able to identify normal ovary. And if it's just the ovary you identify, you then need to look for vasculature of that ovary. But later, when you have been well-grounded and experienced, you'll be able to apply Doppler and evaluate the mass more critical and be able to give your own objective diagnosis.
All right, thank you, sir. There's another question for you here, sir. Please explain the angle of installation for the crown-rump length and the femur length. Angle of installation for crown-rump length and femur length.
Yes. the angle of inclination for all of them should be 90. If you look at what I said, the image, I mean, if you are measuring the crown-rump length, the ideal thing is to get the, what do you call it, the fetus in the sagittal plane. And then your PROF should point at least 90 degrees to that sagittal plane. And then you can take your measurements. The same thing when you are measuring the femoral length. The femur is supposed to be as horizontal as you can get it. And then the angle of inclination should also be 90 degrees. So it's the same 90 degrees if you can be able to